Yes, request control, please.
Okay.
This patient has acute pelvic pain.
So I have requested.
Acute pelvic pain. On. Use the mouse directly. Use
Okay.
the arrows directly.
Okay, sir. Sir, I am provided. No, it's. Am I moving it?
Yes, it is movable.
Okay. So I am provided with MRI of pelvis, sagittal images, T2 sequence, and I could appreciate that the uterus is in the normal position. The junctional zone is intermediate. I could appreciate a large T2 bright lesion likely in the adnexa. In addition to that, I could appreciate a smaller T2 bright lesion in the cul-de-sac as well. So I would like to have a look on T1 sequences.
And I would say thanks to
One second. One second.
avoid
My colleagues,
so
please mute yourself. Victor, can you hear me?
Yes, sir.
Victor, you talk about everything. What is this?
So there's shading noted within the large lesion noted in an anexa, but I want to confirm it. It's if it's on the right or on the left.
What sequence do you want?
So firstly, I want T1 axial images. Sir, I'm provided with T2 axial images, and I could appreciate a large lesion in the right adenexa with shading sign noted within it.
Where is the shading sign? Where?
So the within this
What do you
lesion.
think? What do you think? Shading
Uh,
sign
so,
could be seen in T1.
no.
Okay.
Isn't it
So this is,
T2? The fluid is bright in the spinal canals.
doctor, is this solid or cystic? This is T2. Sorry. This is T1, T2, sorry. This is
Yeah,
T2.
this is T2, yes.
Yes, yes. Okay. This is solid or cystic. There are no
Sir,
shading
I
signs,
think,
by the way.
okay, so then just there's a T2 bright lesion. Uh,
Yes.
so can you show me the post-contrast sequences, T1 post-contrast and T1?
Okay. This is no. Post contrast. Yes.
The T1 post-contrast sequences, I could not appreciate any significant enhancement within this. And
Yes.
the uterus itself is normal. So can I have a look on T1? I haven't seen T1 yet.
Okay, but look here, doctor. What happened here? What happened here? You are in the yeah, correct way. The lesion didn't show any contrast uptake. And what else? What happened here? There are something critical here. The
There,
patient also.
there is
Mm,
there is
mm.
twisting of the pedicle with
Yes, excellent.
suggestion.
Yes, yes, excellent,
Okay, sir.
excellent.
So, but is this the ovary in the abnormal
Oh,
position?
we don't know. Look, look. What happened here? What happened? Look, look.
So over here, I could appreciate.
Mm. What happened?
So this is the this. I think this is the twisting.
Yes, so give me a differential diagnosis.
So I'm thinking of a variant torsion.
Excellent.
Uh,
Right or left? This
right.
twisted with no, this twisted
Right.
pedicle. In the left, on the right, which side?
So the left one appears twisted.
Yes, excellent. What will you do next?
So I would like to inform the primary doctor. So, but I have a question. Why is the right one so enlarged? Is
Uh,
there any
this
underlying
question,
endometrioma?
this question, should I ask you? This is the pedicle, and see,
Okay,
completely dark, and there are a large lesion here,
okay, okay,
large
okay,
lesion here. So it is a left ovarian large lesion, large mass, complicated by or caused torsion.
okay,
Okay. When we
okay,
examine, when we examine the rest of the examination, this mass is high signal in T2 and state, and intermediate, I think intermediate. This is T1 or T2? This is T1. Looks like low to intermediate signal in T1. So
yes,
it is almost fibroid. This is a large
okay,
left ovarian fibroid complicated with torsion. Thank you,
okay,
doctor, so much. My advice to
yes,
you,
sir.
don't talk too much about the normal, and there are a huge lesion here. I give you, this is the first image, and the lesion is very large. Okay. Why I give you from the beginning the lesion? Because the challenge is here. The challenge is in the pedicle. Pedicle is very dark and it looks like twisted. Very good, very nice twisted pedicle in the sagittal. Okay, even in the sagittal post contrast. Avascular, no vascularity in the pedicle, and even in this large mass due to torsion. Thank you, doctor, so much.
Okay,
You did
sir.
very well.
Ovarian fibroid with torsion.
Yes, yes. Thank you.
Yes, sir.
Next candidate. Hello, Omer.
Assalamualaikum.
Salam. This patient presented with acute, acute right iliac fossa pain. Go on. Request control.
Saya I'm from mobile. I cannot
Okay.
control.
Right
These are
iliac
axial sections.
fossa. Yes.
These are axial sections from CT pelvis. Um, appendix appear unremarkable.
Yes.
There is specific density with fat strandings noted.
Excellent. Where?
Uh, Central mesentery.
Yes. But يعني, where is this density? The fat
Uh,
stranding, okay, in the center mesentery, but the density where?
mesentery with the linear hyperdensity
Yes.
noted associated with it.
Okay. Give me a differential diagnosis, doctor.
So it can be, I will take the history of the patient. If there is a history of recent surgery, it can represent gossypyboma, or
No
it can be,
surgery. No
okay,
surgery.
if it is calcific density, it can represent a foreign body. I will check if there is any perforation in the
Okay.
bowel,
Check. There are any
or if there is
perforation here? Tell
if
me
there is
first.
a,
There are any perforation?
I think there is some defect noted in bowel wall.
Excellent.
I
So
will
what's your differential
ingestion, foreign
diagnosis?
body ingestion.
Excellent.
It can be foreign body ingestion with perforation.
What do you know the type of foreign body here?
It can be some fish bone.
More than excellent, doctor. Thank you so much, doctor. Could you, do you want to exclude anything else from this exam?
Um, I will rule out. I will check the lung window to rule out any pneumoperitoneum.
Thank you, doctor, so much. An easy case to pick up this very hard, stressful mixed viva session. Linear, dense foreign body cause perforation in the small bowel. This is the focus or foci of gases and surrounded by smudging peritoneum. So this is a fishbone perforation of the small bowel. Thank you, doctor, so much. And she will rule out any considerable pneumoperitoneum. Next candidate. Next candidate.
Yes, sir. Yes. Good afternoon.
Good afternoon. This patient has a pelvic pain. He is 65, male patient with pelvic pain.
With hip pain,
Pelvic pain, and dysuria. What
there
is
is
what is the name? Tell me the technique first, please.
there is coronal T2 for the pelvis.
Okay.
It is candid 12.
Okay, doctor, continue. No problem. No problem. Go on.
There is a coronal T2 image for male pelvis.
Yes.
Sorry, I will scroll.
I'm scrolling.
Yes. I will scroll and say my opinion. The urinary bladder is average capacity and good distended and with normal wall, no
So
intraluminal test.
do you think this examination is done for a pelvic purpose or something else? I told you he have a pelvic pain and it is Syria, but the technique here dedicated for which organ of the pelvis in the male
For
pelvis?
for
Yes.
prostate.
So
For
this is
prostate, yes.
MRI prostate. Okay.
Yes.
Go on.
Yes.
What happened?
Yes, there is an focal lesion of low signal within the peripheral zone of the prostate on the right side. This
Okay.
focal lesion
See,
display
low signal or low T2 signal because it is
yes, low signal
very
NT2.
important.
Low,
Yeah,
yes,
very important
yes,
in prostate. Yes.
yes.
Where is the lesion?
The lesion in the right side of the peripheral zone of the prostate.
Excellent. Okay. Which sequence do you want to see after that?
I want heavy T2 post contrast dynamic study post contrast and diffusion weighted image.
Which of them, if you should choose one of them, which one you should choose?
Post contrast dynamic study.
In your practice, you see the host contrast before the diffusion.
Diffusion is good. Yes, diffusion is better.
So which one you should see first? Diffusion.
Diffusion weighted image.
Okay, diffusion first. This is the diffusion.
This is T1 post contrast, I say.
Yeah, this
is diffusion. Diffusion weighted image cuts. We can appreciate the previously seen focal lesion in the right side of the peripheral zone shows bright signal. Bright signal here, restricted diffusion. Diffusion suggestive of a neoplastic nature.
neoplastic rate. Which neoplastic in prostate? What is the name of neoplasm? Is this malignant or benign?
لا لا
Prostate.
malignant.
So what is the
adenocarcinoma?
Yes. Okay. Okay. You told me only the lesion in the periphery of the T2 right periphery. But look here. See, this is the periphery. Okay. But look here. What about this? What do you think? This is another lesion in the central zone or not? Look here. See.
I think it's the same lesion but extending within the central zone.
Okay. And what about this normal tissue in between?
The seminal vesicle. Sorry.
No, this is not the seminal. See, the seminal vesicle is this.
Sorry.
Okay. So there are two lesions. One in the right side of the central area and one in the right side of
Peripheral zone.
peripheral zone. Okay, this is post contrast dynamic. What do you think?
Yes, we can see enhancement, non-homogeneous significant enhancement at the early arterial phase.
What
This
else?
is early arterial phase.
Sorry. What else? There are something very important here. What else? Look, look to the
I want to
capsule.
see
Do you think
its
the
relation,
capsule? Yes,
relation with the seminal vesicle and the neurovascular bundle to detect
this
the
is the
stage.
okay. This is the seminal vesicle.
Uh, I
In
think it
which,
is
hmm, yes,
inseparable from the seminal vesicle on the right side.
in inseparable. No, see
Yes.
the seminal vesicle is here. Separable. Okay? It's separable.
Okay.
So for your final diagnosis, please.
We do I want to do كمان endoscopic lower endoscopy and biopsy, take many biopsies and histopathology.
Yes.
First
What is your
diagnosis,
diagnosis? What is your diagnosis?
adenocarcinoma, cancer prostate adenocarcinoma.
Thank you, doctor, so much. You did very well. See my colleagues here. This is a T2 MRI prostate. Okay, not pelvis. Okay, it is take some pelvic organ, but this examination is dedicated for prostate. Second point, look here. At least there are lesion here, and this is very dark. I think there are a sign called the charcoal sign. Okay, so next step from T2, exclude any seminal vesicle invasion in T2. T2 is the correct sequence to exclude any seminal vesicle. Why? Because it is very, it is bright. If there are any invasion, this brightness will be lost. Then the next sequence to be examined, not only the diffusion, no, the EDC, very important. What I'm talking like a practice. Look at the EDC here. If you find any diffusion, any low EDC, compare with diffusion. Low, high, then low, then then you will uh, you will see this one. Okay. Low and high. If you notice here, there are a bulging. There are some capsular breach or infiltration. This is at least grade 5 or by rate 5. It is not يعني requested in the exam to tell which by rate, but at least this is cancer prostate. Thank you, doctor, so much. Next candidate.
Sir, we have a confusion in the ovarian torsion case. Was that ovarian fibroma or ovarian fibroid?
What, fibroma or what?
Sir, or ovarian fibroid.
It is ovarian fibroma. And what is the difference between of fibroma or fibroid? Both of them are are a smooth muscle benign tumor.
Okay.
Even we are confused. Both of them
So I
are
have a
a small
question. The
number.
fibroma are T1 and T2 dark. The lesion was bright on T2 with some shading like.
Okay, okay, doctor. Why the lesion is bright in T2? Okay, let's explain. You are correct. In fibroma, it should not be bright in T2. You are correct. But here, what the lesion? Why the lesion is bright in T2? Because of the pathology. What is the pathology here? Torsion. And in torsion, there are edema. Correct? See, in
So
any
but how
case,
would we differentiate it from?
See,
from an
in
individual.
any case, of ovarian torsion, you should find a significant ovarian edema. That is correct or not? Doctor,
Yes.
Yes, sir.
can you hear me?
Yes, sir.
Yeah. In any type of ovarian torsion, you find some edema in the ovary because of ischemia. Okay? You can consider this slightly bright signal as a part of edema because due to this torsion, there are ischemia for the whole left ovary and the left fibroma. Okay? All of them will be edematous. But here you can detect the left ovary because the lesion is so large. It's 12 centimeter. Okay, doctor? This is right.
Okay.
Do you need any explanation?
Not
No?
from my side. Yes.
Okay. The asking doctor, do you need any other explanation? She disappeared. No problem.
No,
My colleagues,
No, sir.
please.
Thank you so much.
no, sir. No, sir. Thank you.
Okay. Okay. This case is a very interesting case and very difficult case, by the way. Okay.
Yes.
What happened here? A large lesion connecting to a black pedicle hair. Where is this black? Oh, this black become coma shape. Oh, this is a spiral. Oh, this is not a spiral. This is twisted. This twisted, and it looks like there are some vessels within it. Oh, so this is a vascular pedicle. If you go to the axial one, you will see here the pedicle to the left. So it is better in huge lesion, especially in the pelvis. Don't from the beginning. Don't tell this is the pedicle by. Don't tell this right or left in the beginning of the exam because see this patient came from the left and to the right. What is the evidence? The uterus is see the uterus. The uterus is shifted to the right. So this is a left origin. The pedicle here in the left. Thank you, doctor, so much.
Okay.
Next candidate.
Candidate number 13.
Yes, I'm here.
Okay.
Did we finish this? Yes. One second. Yes, 37. Okay. Okay. Doctor, this patient presented with new onset 30-year-old male patient presented with a new onset of seizure.
Okay. Can I ask remote control?
Yes. Go.
Okay. 1 second. No, it's not. Yes. Okay. I've been provided with axial cut CT brain for a 30 years old male coming with new onset of seizures. I can see. Sorry, sir, it's not scrolling well. Could
Yeah,
you
I will
please
scroll. I will scroll.
Okay. Okay.
Unit one.
This axial cut, it's non-contrasted CT axial cut. I can see that there is evidence of hypodensity noted within the left frontal and left parietal lobe in the deep white matter. I just want to know the extension of it and exactly, okay, it's in the subcortical area and the deep white matter.
And
Oh,
not only
and
the what? Yes,
sorry.
involving. Yes, go on.
Okay, it's extending also slightly to the left occipital, deep white matter region.
Where
I
is the
couldn't.
lesion, doctor? Show me by the
Yes,
mouse. Where is it?
here, this all hypodensity signals. That
Okay.
is in the subcortical region.
Yes. Okay.
Okay. And also it extends to the posterior aspect of the left frontal and extending down slightly surrounding until the
Look
okay.
inside this. See. Look inside this.
Okay.
Stop here. Stop it. Look
Okay,
inside this
in this,
hypotenusity.
this I can see also in the left basal ganglia that there is evidence of hypotenusity, maybe surrounded by high in hyperdense rim. So this could be a lesion in the left basal ganglia region,
Excellent.
surrounded by
Yes.
marked edema.
Yes. What will you do
I
next?
would ask for CT with contrast.
Okay. This is MRI.
Okay. In the MRI T2, I can see that the lesion that noted before in the CT, it is the same in the left basal ganglia region. It shows hyperintense signal within and the hypointense rim, and there is a massive edema surrounding, which cause a compression to the left lateral ventricle and with the
Excellent.
midline shift. Sorry?
Excellent. Excellent.
Okay. With midline shifting and also I couldn't see any other lesion. Okay. Just I want to see with the contrast, and also I want to see the restricted diffusion images. And with the restricted diffusion, I have to confirm with the ADC.
This
Okay.
is
Okay.
1 second. Okay. Can I go on?
Okay. I can see that there is evidence of restricted diffusion within the lesion. However, the rim is
Where?
appearing.
Where?
It's
Which
iso
part?
intense.
Which part is restricted?
The central. Sorry, just 1 second. It's slightly the center of the region.
Sure. This
No,
is
no,
the
no.
center.
It is
Not
sorry. Okay. So it's only the peripheral rim of the region
okay.
is
So what's your
restricted.
difference? Okay, what's your
Okay.
differential? What's your differential? Correct. Yes.
It could be myths. It could be myths
Okay.
in the post-contrast enhancement, showing that there is evidence of peripheral enhancement. However, the wall of this lesion appearing appearing irregular. And also, I want to look for the meninges because if there is myths, maybe there is evidence of meningeal carcinomatosis.
What is the name of this appearance? It's very characteristic.
Incomplete ring enhancement in the region. Sorry, can you go back there? I want to be sure about this incomplete rim, but this is complete.
Yes.
This is complete rim
another
enhancement.
This is another name. Give me another name.
Ring
name?
enhanced lesion.
Okay. Ring inside ring.
Enhanced lesion. Yeah.
Yeah. What is what is the name of this appearance?
Yes, this could be abscess with daughter abscess within, or could be
But in diffusion, look.
but in the diffusion, yes, that's what this last likely because it's in the diffusion. There is no restricted diffusion for the center of this lesion, so it could be abscess. Sorry, it could be myths. Could
okay,
be
what
myths.
else? What else?
Could be this. I don't want to say MS, thermofactive MS, because it's a complete ring. I can see it's complete. I don't know if this. In some areas, it show complete ring enhancement. In other areas, it show incomplete.
Doctor, what do you
but
think?
I don't think also this massive edema is coming with tumefactive MS.
And
so my provisional diagnosis for this would be MITS. Again, MITS.
Okay. What else? if you remember the history, the patient is still young,
Yes,
30
if
years
it's still
old.
young,
What else?
uh,
You talk about the tumoral possibility. This is good. What else?
so it could be infection,
What type of infection?
TB, like TB, tuberculoma, or something like this. It's
Tuberculoma,
sarcoidosis,
no,
or
tuberculoma has low T2 center. See, low,
yes.
not high. What else?
So if this patient has maybe immunocompromised,
Yes. Hmm?
it could be a herpes lesion.
In immunodeficiency, especially AIDS,
Yes,
what is the first possible infection? Brain
the
infection.
first possible infection would be in the immune compromised would be toxoplasmosis,
Okay,
could be or
excellent.
TB.
How could you
So,
differentiate between being a tumoral in nature or toxoplasmosis? What sequence do you want?
uh, just um, toxoplasmosis. Sorry, this is maybe MR spectroscope, the spectroscope
Excellent,
infection and
excellent,
the
excellent,
tumor. In the
excellent.
tumor, it would be increased the creatinine choline ratio, but in the infection, it would be, as I remember, because I'm not sure, but maybe there
Give
is increase
me,
of lactic
doctor,
acid or.
doctor, this is MR spectroscopy. Give me your final diagnosis, please.
Okay, this is N-acetylcholine, increasing the N-acetylcholine, um, N-acetyl increasing, but the creatine choline ratio uh, slightly decreases, so it's not tumor.
So
Increase
it
creatine.
is.
It's not a tumor, it's
Okay.
an infection,
Thank you, doctor,
like
so much.
toxoplasmosis.
This is a toxoplasmosis. Thank you, doctor, so much. It is a very difficult case. As you see, my colleagues, this I will start from MR, okay, or from CT. Don't forget, my colleagues, this is okay, edema. It's very obvious. But edema is not the main pathology. There are ring hypertension here in the basal ganglia, and this is a classic toxoplasmosis. When we did an MRI, okay, MRI confirmed. I'd like to thank you because you didn't repeat the finding of TB of the CT. Confirm the CT finding. Plus, you did very well when you mentioned this midline shift and massive effect, and you should tell the examiner if there are ankle herniation or not. Second, you did very well when you ask for diffusion restriction. This is only restricted diffusion at the periphery, comparing with DC. Okay, this is DC. And here, this is the characteristic sign, concentric ring of enhancement, concentric target sign. This is very characteristic, very characteristic to toxoplasmosis. Okay, you did very well when you told me I wanted to examine MR spectroscopy. The only thing you forget, as I told you before in many lecture, my colleagues try to ask for sagittal post-contrast, especially in tumoral case, to rule out number one, consular herniation, because there are massive cerebral edema. Number two, any skull base infiltration, destruction, whatever. Number three, meningeal deposits. Leptomeningeal deposits here in the basal cistern is very common. And in granulomatous disease also, you should check here the basal cistern and the meninges here. Okay, so three critical signs should be excluded in any tumoral brain case. Ask the examiner for sagittal, either T2, either post-contrast, and tell him I will exclude tonsillar herniation, skull base infiltration, and the basal cistern. Like this, the examiner will trust you so much. Okay, he will be very happy. Why? You are very safe, doctor. Thank you, doctor, so much. It was a very difficult case. Next candidate.
Assalamu sir. Nice to meet you.
Welcome.
Hello. Sir, you
Yes.
can stroke for me? Yes, sir. Information disclosure.
Patient has a chest and abdominal pain.
Okay, sir. Okay, sir. I'm observing an CT scan pain study of an adult patient, chest and abdomen. I can appreciate there's some vascular calcification.
Well,
So it is around the okay, sir. There's some line within the IVC. There is an reduced density noted within the IVC as well as the wall of
excellent. What else?
aorta. And
Yes. Else.
also some calcification also around the pulmonary vessels will be segmental branches. It's not in the main, but segmental branches shows calcification.
Why this is a unilateral calcification?
Maybe that
It is
calcification.
almost on the right side.
Okay, sir.
One second.
Sir, maybe
Yes, go on.
yes, sir. So, any thrombus pulmonary embolism which may only involve the right side of the pulmonary artery.
Okay, if I show you this, what's your differential diagnosis?
Sir, there's a compression collapse of L5 vertebrae.
Okay,
Okay, sir, there's an end
and
plate sclerosis is there with T vertebral as this post vertebral calcification and soft tissue component in the pre-vertebral area.
Doctor, what
Yes,
happened here? You said there are compression. And what happened after
compression collapse
compression?
of
Yes, and what happened here?
so some retropulsion is there and some
What happened here,
is
doctor?
okay, sir, anterior
After collapse.
L4 vertebra collapse. Is there some sequestration or some
Okay,
bone?
good.
Yes.
After the patient has collapsed, there are some treatment. What is the name of procedure here?
Okay, sir, any disc reversing? There's some put some sediment object to
Okay,
maintain
cementoblast.
its height. Yes.
Okay, so could you give me a reasonable diagnosis here?
Sir,
What is this?
okay, sir,
What is
there may
this? What is
sir,
this?
there is some thrombosis or no?
What is
Okay, sir.
this?
Sir, there's a calcification.
And what is
Mine
this?
is okay, sir. This cement is seen to be in thrombose within the IVC, then the right atrium, and then the pulmonary
Hey,
vasculature.
doctor, what happened for the pulmonary vessels here? What go
So they are
inside it?
okay, so they are
Not calc
calcified or some
not
cement objects
calcification.
that
Yes. So this is
yes, sir.
a cement embolism, pulmonary embolism.
Embolism.
Okay. And what happened in the IVC? What happened
IVC. There
here?
is
What happened?
they put
What
a
is this?
stent, sir.
Yes, missed stent. Thank you, doctor, so much.
Yes,
By the way, my colleagues, this is a case of cement embolism within the pulmonary arteries and missed or retained IVC stent. In the Radiopedia, they mention or they diagnose the IVC also is as a semen, but I think no, this is a catheter. I think also Dr. Sami Khan shows this case before and he comment on this as a catheter. Thank you, doctor, so much. Did very well. Next candidate.
Hi, doctor. How are you?
Hi, how are you?
Yeah, all good.
This
Okay.
patient has, please, there are some air in your mic. See, this 7-year-old, not 7, second, 1-year-old male patient presented with abdominal distension. Go on.
Okay, this is a abdomen radiograph for a 1-year-old male patient presented with abdominal distension. I can see that the bowel loops, there is a fecal loading seen in the rectum. Uh, no abnormal air seen to denote the pneumoperitoneum. But I can see there is like air in the bowel wall seen in the left lower quadrant.
Yes.
So I'm suspecting that this is nematosis intestinalis. I would like to rule out if there is any portal gas seen. So, but I can't see any portal branching gases over the liver.
Yes. Do you find any major normality here?
I think
Yes or no?
the abdomen is distended, maybe acidic fluid.
No acidic fluid, doctor. No acidic
No.
fluid.
Okay.
Do you find
So,
any other major abnormality here? Yes or no?
yes, this is the air in the bowel wall.
No, the bowel is normal. It's normal.
Okay. No.
Okay, what do you want to do next?
I want to check if there is any CT for the patient.
It's a CT.
Okay, this is an axial cuts for CT. Abdomen. Yes, there is air filled. Oh, sorry. Okay. No, this is the liver. The liver is seen enlarged with hypodense areas.
Yes.
No, this is not the liver. There is a lesion down there seen in the right lower quadrant, heterogeneous with multiple cystic areas.
Yes. What's your differential in 1-year-old patient?
The kidneys looks fine.
Please try don't expirate in them. Please. Yeah, go on. Go on. Yes, this is the lesion.
Okay.
Give me a differential in 1 year.
1-year-old. This is. Can I check the kidneys? This is not arising from the kidneys or suprarenal, right? Yeah, the kidneys looks fine, and the suprarenal. Okay.
See, doctor, what happened here? Is the lesion continuous with the liver or not?
Yeah, the lesion is continuous with the right hepatic loop.
Okay, so it is a hepatic lesion.
This is hepatic lesion.
Give me a differential diagnosis in
In
1-year-old patient.
1-year-old, this is
Yes, correct.
hepatoblastoma.
Okay, what else? But hepatoblastoma is almost solid, not cystic. What else? What else? Enumerate. What else?
I can't remember actually. There's another tumors.
No problem. It is mainly cystic, and they show some solid. Okay.
Yes.
So do you expect this?
Endothelioma.
Okay, hemangioendothelioma, but hemangioendothelioma will show gradual peeling towards the center, and if in the arterial peripheral nodular enhancement. So we exclude two possibilities. Last possibility, do you hear about a congenital hepatic mesenchymal hamartoma? This is a congenital hepatic mesenchymal hamartoma. And how to differentiate? It is mainly cystic. More than 80% of it is cystic. And this is the clue of differentiation from the hepatoblastoma. Second point, hemangioendothelioma, like hemangioma, giving the closing iris site. Okay. Thank you, doctor, so much. And
Okay,
thank
thank you.
you that you pick up this hepatic, not renal, not suprarenal. And this is very important. And it was the clue to rule out renal and the suprarenal. This is this is a congenital hepatic mesenchymal hemorrhage. Thank you so much.
Okay, thank you, doctor.
It's candidate.
Hello.
My colleague,
Hi.
I have one advice for all of you. See, if you have a case like this, and you told the examiner this is a huge adnexal lesion, okay? It's pedicle originate from the left. It's pedicle in the post contrast. So no any contrast take. I have a high suspicion of torsion. He will give you a very good mark. Okay, don't be worried about more and more details. The examiner he don't need from you either this fibroma, whatever the pathology, because the diagnosis which are mentioned in Radiopedia, most of it are post-surgical. Okay, this is a large left adnexal lesion, and in any large left adnexal lesion more than 5 cm, we are worried about torsion. خلاص, you like this, you smash the case. Okay, either this fibroma, whatever the nature of um, the pathology. So don't worry, don't worry. It will add nothing to the exam. The most important the torsion, and he should demarcate anyone lose torsion. Why? Because in any lesion above 5 cm in ovary, we should talk about torsion. A 50-year-old male patient complaining of sudden calf pain and tail pop during sports on
Left pop, sudden calf pain and left pop during spot. Okay, this is um, ankle radiograph, lateral projection of adult patient having history of calf pain. I can appreciate on the lateral view, there was small bony fragment adjacent to the inferior border of the calcaneum, anterior aspect of inferior border of the calcaneum. This is likely
don't
giving a fracture.
don't worry
Okay,
about it. What else?
okay. I am looking at the Achilles tendon. There is, I think, there is radiolucency, a linear radiolucent line in the Achilles tendon, and also I am suspecting somewhat irregularity uh, along the outline of the Achilles tendon. So
What will you do
this
next? What will you do next?
I will do MRI, and also I
Why?
will help from the ultrasound if available.
This is ultrasound.
Okay, ultrasound grayscale images, these show discontinuity between the fibers, and also there is a region of low echogenicity showing internal areas of echoes, and also involving the subcutaneous tissues underneath the skin on back of the Achilles tendon, and also I'm suspecting some break irregularity and break in the tendon.
What's your final diagnosis?
It could represent acute Achilles tendon rupture with the hematoma, with acute hematoma in the tendon.
Thank you, doctor,
Um,
so much. You are
possibility.
brilliant. Thank you. This is very difficult case, despite it is an X-ray and ultrasound, but really very difficult because most of us will be crazed by this. But the clue is here. See here, and see this. At least there are some abnormality here. If you told the examiner, at least there are some abnormality, and the tendon here is corrugated. This is the muscle. This is the tendon. Go up here in the tendo junction between the tendon and the muscle, musculotendinous junction, there are at least abnormality. If you told the examiner, I could pick up abnormality here, I want to do ultrasound, he will be happy. Okay, and in ultrasound it is very clear there are complete rupture. See this gap, very wide, very nice gap. See, measure from here to here, it may be about 3.8, about 4 cm, complete rupture of the Achilles tendon. Next candidate.
Welcome, sir. Sir, should I request control?
Yes, please. 40-year-old
Sir, I request
female patient. Forty-years-old female patient complaining of pelvic pain.
Sir, I've been presented with the CT scan axial section with the ascending CT cystogram, in which I can see the Foley's catheter in situ along with the contrast, and there are a few air bubbles.
Yes.
The uterus is like edematous and large,
Excellent.
likely secondary to the delivery.
Excellent. Excellent.
I am not able to visualize any sort of fistulous communication between the bladder, or no extravasation of contrast is seen.
Excellent. What happened here? What happened
Sir,
here?
there is
Status post.
Sorry,
Status post. This
yes,
is
sir.
a
These
status post.
post-surgical changes, changes in the anti-abdominal wall. Apart from
What
this,
section?
there is
What section do you want?
Cesarean section, sir.
Yes, yes. What CT section do you want, or plane?
The post-contrast sagittal.
No, post sagittal. This is a sagittal. What happened?
Yes,
Tell
sir.
me.
Sir, in the sagittal view, I can see there is a diverticular formation, outpouching that is seen from the dome of the bladder, and it is that might represent the extravasation of contrast from the bladder secondary to the rupture, or maybe because post-surgical stitch, you can say.
Thank you, doctor. You did very well. Especially, I hide the most important part of the history. There are a section here, and many examiner will do like this, because if I told you there are a section, you will easily pick up the finding. There are superior outpouching, but actually this is a rupture. Okay, a rupture due to injury during the CS, and it is very common in the practice. Leave the mouse, please. Leave the mouse. Very common, either fistula tract or injury or rupture, whatever. But at least this is irregularity. It may be a contained rupture, because there are no spilling of the contrast outside this pouch. This is post-surgical, post-CS injury or rupture of the urinary bladder. Thank you, doctor, so much. Next candidate.
Yes, sir. Assalamu alaikum.
Salam. 60-year-old female patient presented with dyspnea.
Okay, should I request remote control?
No need.
Okay, so I'm presented with a CT scan. Sorry?
Yes. Yes, yes. Go on. Okay. Go on.
Okay, these are the CT scan axial sections at the level of aortic arch of the chest, mediastinal window.
Yes.
I think there is lag in scrolling.
Let me scroll for you, please.
Yeah, sure.
The patient has dyspnea, old age, 60-year-old female patient with dyspnea.
Okay, so I'm presented with CT scan chest axial sections with the history of dyspnea of an elderly patient. I'm looking at the vessels to look for any sign of pulmonary embolism as the patient has dyspnea. I cannot see any gross pulmonary embolism. There is, yes, I like to see the pulmonary arteries. And
Look at this slide. Look what happened here.
I can see the left coronary artery seen arising from the left coronary cusp. And bilateral breast shadows are intact. However, a soft tissue density lesion is seen in the right breast region,
Yes, yes,
the
doctor.
quadrant with some calcific density in it.
Excellent.
Yes.
Yes.
So
What is your next step?
I like to see the axilla for any lymph node and lung window to look for any metastasis, as it's a dense mass and looks like a malignant lesion. And I
What
also
will you, doctor? What will you do for this patient next? Patient with left breast mass and the calcification. What will you do next?
next I will inform the clinical findings to the different clinician and will advise staging scan with an MDT discussion and refer to best breast clinic.
What is this, doctor?
Okay, this is mammogram, where I can see that there are specks of microcalcification seen in the right breast in the upper quadrant, sorry, in the outer quadrant, along with in a
This is
popcorn
upper,
calcification
doctor.
seen in the
Doctor,
quid.
this is upper
Sorry,
or outer? This is upper or outer?
this is see in the craniocaudal view. This is
Yeah.
the outer quadrant. Yeah.
No. This is craniocaudal. So this is upper,
Yes.
this is lower. So this is
Yes.
upper.
Okay.
Yes.
Yes.
What will you do next, doctor? What's your
Next,
differential here?
my differential of the leomorphic calcification and the dense lesion. So it's likely an M5 lesion. I like to do the ultrasound of this lesion, and if there is a lesion in the ultrasound, then we'll do the ultrasound guided biopsy. Otherwise, stereotactic biopsy of
Is
this lesion.
ultrasound? Is the ultrasound? Go on. Hello?
Yeah. So on the ultrasound, I can see that there is a lobulated hypoechoic lesion.
Is this
With
lobulated
the
or irregular? Doctor, this is lobulated or irregular?
irregular, ill-defined margins.
So what's your differential diagnosis?
My differential would be of a Barrett's 5 lesion.
Thank you, doctor, so much. Take care, my friends from film sites.
Yes.
Take care. Very critical. Especially, I stress in the history, 60 years old female patient.
Yes.
Okay? And the rest, okay, thank you, doctor. The memo, I think, is typical and ultrasound is so typical. Take care, my friends. See how to differentiate very dense. Please, mouse, doctor, please. The mass is very dense in comparison with the rest of breast tissue. And by the way, this breast tissue is too much, really, in comparison to 80-year-old. Really, it's too much. I don't know why. Next candidate.
السلام
Hello.
عليكم.
Assalam. This patient has abdominal pain. 55
I want
female
to.
patient with abdominal pain. Go on.
I have been presented with abdomen CT scan with IV contrast for an adult patient, female patient with a history of abdominal pain. In my routine practice, I will take a general look for this CT scan until the last cut. Then I will come back to my observation. Okay, we are scrolling down into the pelvis. I can see, okay, until the last cut, please. Okay. This is a pelvis CT scan. I can see that the hernial orifices appears intact. I noticed that there is dilatation of the tubular blind ended structure seen in the right iliac fossa, which is surrounding
Excellent.
by smudging of the. Sorry?
Excellent. Excellent.
Excellent. Okay. By smudging of the surrounding mesentery, and there is also sub-centimeter lymph node enlargement.
What's your
I in my
diagnosis,
routine
doctor?
practice,
Doctor,
this is a
what's your
case of
diagnosis?
case
Yes.
of acute appendicitis. I
Which
cannot see any
which
evidence of.
say
Sorry?
which type of acute appendicitis? Which type? Why this patient has a right upper abdominal vein? Where is the appendix? Hello? Hello? Could you hear me, doctor? Dr. Omer, my voice is audible?
Yes, sir. Yes, sir. Candidate 20, can you listen?
Okay, maybe disconnected. Thank you. Thank you so much, doctor.
Which is, can you hear
Yeah,
me?
Yes, yes,
okay.
he's asking.
Give me a final diagnosis. Which type of appendicitis? Hello? Hello? Okay. To save time, this is acute subhepatic appendicitis, my colleagues. Okay, this is a very common tricky case in the exam. You should rule out any perforation, and you should rule out any mesenteric vascular venous thrombosis. And you as usual, you will ask for the lung polyp, rule out any pneumoperitoneum. Thank you, doctor, so much. You pick up it very easily, and you are brilliant. Next candidate.
Sir, we have end of our list here.
Okay. Everyone take a chance today.
Yes, sir.
Dr. Omer, our
Yes, sir.
list
Most of the
finished.
yes, sir. Our list is finished.
Yeah. Anyone wanted to participate? I think I have or 3 cases still in my session. Anyone
Yes, sir.
want to?
Sir, me
I
too.
want to participate.
But يعني please who give a
Okay,
chance who.
Sir, Dr. Vishnu, he's a June candidate. We should give him next time.
Okay.
Dr. Vishnu.
Okay. Welcome, doctor.
Yes,
Welcome,
sir.
Dr. Vishnu. 65-year-old female patient complaining of dyspnea. Go on, doctor.
Here I am presented with the chest X-ray of a 65-year-old female patient who presented with the dyspnea, bilateral lungs here look me hyperinflated. And there is a well-defined rounded soft tissue density area is noted in the right mid-zone. The lower border of the lesion is not clearly seen.
Excellent.
And apart from that, there are few other nodular opacities are also there. So it's more than 3 centimeters. So it's concerning for me in an old age patient whose lungs are hyperinflated. It can be a malignant mass. I am checking for the another lesions as well in the lung parenchyma.
Yes. 1 second. What
And
will you do next? What will you do next?
I will go for the contrast enhanced CT scan test.
Okay. Go on, doctor. Hello, doctor.
Yeah.
Hello. Go on.
Hello. Yes, I am here, sir.
Yes. Go on.
So I just want to see the lung images again because there is a large vascular channel is there.
Yes.
Bilateral pulmonary arteries are enlarged in size.
Yes.
No, there is a right side aortic arch is there.
Yes. Excellent. Excellent. Really. What else?
And there is a aneurysm of right. I just want to see this. There is a large vascular structure there on the right side. I just want to see that it is pulmonary artery aneurysm. I want to see
Excellent.
in the core.
Go.
Hello.
Yes, go on. From where?
Then there pulmonary thromboembolism is there in the left
Okay.
side, and
Okay.
that is
Look.
eccentrically placed. So this can be the chronic pulmonary thromboembolism.
Excellent, excellent. But tell me the origin of pulmonary artery. See, where is the origin? From where the pulmonary originate?
Yes.
What is this?
Yeah, this is this is arising from the LV.
No, not LV. Concentrate again, doctor. See, doctor, see. This is the aorta. Okay, this is the aorta. Go. Okay, and where? See, from where both pulmonary artery originate. See, the same origin of aorta gave something else.
Yes.
See?
Both are arising. This is double outlet right ventricle. Both channels are arising.
Okay, yeah, you are correct. See, the aorta and the pulmonary artery originate simultaneously. So
Yes,
what is the
this is
name of this condition?
truncus arteriosus. Common
Excellent.
origin of the
Truncus arteriosus. Excellent. The pulmonary artery and the aorta originate by a common origin. Okay, my colleagues. Besides that, there are marked enlargement of the right main trunk and mural thrombus of the left pulmonary artery. Okay, plus right aortic arch. How could this circulation? The circulation is contained. There are a VSD here. I don't know if you can detect it or not. Anyway, this is a very good case. A very good case of a congenital heart anomaly in the Viva exam. See, common origin
yes
for both of them. Okay.
Okay.
There should be a VST, but really I couldn't see it. Anyway, thank you, doctor, so much. The case is difficult, especially the patient is an old age. What's your management? Would you tell me? And this is very important. Tell me the management in this case, in this age.
Because there is a pulmonary thromboembolism is there, so it is an urgent finding, so it should be immediately conveyed to the referring physician. And there is a RV strain as well, and there is a reflux is also there, that should be also mentioned. And there is a
Doctor, see, this looks like chronic. There are calcification.
Yes.
What do you
Yes.
think this patient need to be managed surgically or medically?
This patient should be managed medically.
Yes,
because
thank you,
it's a
doctor.
old
Old age. Thank you so much, doctor. You did very, very well, really. Dr. Omer,
Thank you.
do we have any other candidate?
Yes, sir. We have two candidates. Candidate number, I have renamed them 22 and 23. Candidate number 22, please unmute yourself.
Hello.
Hello, doctor. Welcome.
Thank you.
13-year-old male patient presented with an obstructive nasal symptom and epistaxis. Would you request control? Or shall I scroll for you?
Scroll for me, it's better. Thank you.
Okay.
I'm presented with MRI axial section T1. I see that there is a large lobulated mass centered on the ethmoid sinus and extended into the right orbital cavity, also extend to the postnasal space and
Are you sure, doctor? Doctor, are you sure it is extended to the orbital cavity? No extension.
Yes.
No extension to right orbit. Okay.
Okay. Okay. It
So
extended to the region of the cella and encasing the both internal carotid. It shows homogeneous intense enhancement. Its lobulated outline. It's in contact with the clivus, but there is no infiltration into the clivus. It's causing pressure effect on the optic chiasm and encasing the.
Doctor, see, no extension to the cell itself or in encasing of both ICA.
Close
See,
contact
doctor.
with.
Yeah. Don't insinuate yourself in too much dangerous description. Okay. It is better to say that it is extended to the nasopharynx. Very easy. See, doctor, tell me first, what are you thinking about before you describe what is the differential diagnosis for this case in
Okay,
your mind?
As the lesion is intensely enhancing and it causing epistaxis in a teenager, then I will think about angioma. It's fibroma.
Okay, so you are describing
it's a benign, but
nasopharyngeal. Yes. See. You are describing a nasopharyngeal benign tumor. From the beginning, you must put yourself in the correct track. I'm describing a benign. Where? In the nasopharynx. Okay, especially in highly vascular because it is a young age. This is very important. Three point to run within it. Okay. So what is this? What is this inside the tumor?
This may be fluvoid. It may suggest visible. Yes, it's a highly vascular tumor.
So, how could you manage this patient?
It's referring to the ENT surgeon and also to the IR team because it needs embolization of the branch of the internal branch of the.
The surgeon wanted to take the patient immediately to the OT. What will you say to him? What will you say to him?
It needs the referral to the IR team.
Why?
Because this is a highly vascular tumor. It needs embolization of the feeding artery.
Excellent. Thank you, doctor, so much. It is a benign nasopharyngeal angiofibroma. Take care, my colleagues. It sometimes takes very small, but within a unique location, sphenopalatine forum. Thank you, doctor, so much. Next candidate.
Yes, sir. Good evening, sir.
Good evening. Do you want an easy case or tricky case? Because we are in the really, I'm not joking. Because we are in the end of the session and I have both. What do you want?
Easy case.
Easy case. 1 second. I will give you easy case. Okay. Because this is very difficult. I think this very, very nice case. Okay. 67 female patient with right heel pain, tinnitus, and headache.
I'm presented with axial T2 weighted images of a 35-year-old patient who presented with ear pain, tinnitus, and headache, and also right facial pain. I can appreciate an abnormal T2 hyperintensity lobulated lesion centered in the right cerebellopontine angle, causing mass effect in the right middle cerebellar peduncle and with extension to right internal auditory canal.
What is the name of this sign? Yeah, give me.
Ice
Give me
cream
a good
cone
password.
sign.
Excellent. So, what's your differential?
My primary differential would be that of an acoustic schwannoma. My second differential would be that of an epidermoid. Okay, on post-contrast sequence, it shows avid enhancement.
Okay. Thank you. What else in this CT? I will not give you an easy case for free. I must
Okay.
put one on
I could see
but
some
this, yes,
T1 hyperintensity along the tectal
excellent,
plate.
excellent.
So this could
So,
represent tectal plate glioma or lipoma, sir.
glioma or lipoma,
Lipoma, sir.
how could you confirm,
Sir, I would
how
like to
could
see a T1 non-contrast image.
contrast? Are you sure?
No, non-contrast image, sir.
Are you sure also? This is T1
Post-con.
Yeah, okay. If I show you a T1 non-contrast, what is the difference? How
It is
to
showing fat signal intensity in
yeah. How could confirm a diagnosis of lipoma? Which sequence?
fat suppression sequence, sir.
Okay, like this, you are correct. Okay, thank you, doctor, so much. It is a
Thank you, sir.
good double pathology. Don't forget my colleagues. Even every time I repeat this advice. In very obvious lesion, don't trust the examiner. He must hide something. Okay, he must hide something. Okay, see my colleagues. Viva exam should contain many case scenarios like film age or double pathology or subtle finding or long case scenario. The four examiners should cover all type of scenarios. Okay, thank you, doctor, so much. Dr.
Thank you,
Umair,
sir.
do we have any examiner, any candidate?
Yes, sir. We have one candidate. Number 24, you can unmute yourself.
Good evening, sir.
Good evening. 1 second.
Yes, sir.
I will give you a very nice case. But this is very nice for me. I don't know. Inshallah, it will be very nice for you. Don't worry.
Yes, sir.
I think this one. 1 second. Yes.
Sir, I have requested for remote control.
Okay. 55-year-old female, male patient. 1 second. With abdominal pain, weight loss, and chronic microcytic anemia.
Okay. I've been presented with the post-contrast CT abdomen pelvis images of a 65-year-old patient. I'll just take a moment to look through the scan. Sir, can I scroll through the images? Ma'am? Okay. I've been provided on the visualized sections. I'll look at each organ one by one. The liver and both the kidneys appear normal.
Doctor, don't worry
Yeah.
about solid organ.
Yeah. There appears to be so there was an heterogeneous area in the epigastric. So I'll just like to. So can I scroll through the images on there?
Yes.
So can you please repeat the history of the patient? Sorry, sir. So
Leave the mouse. Leave the mouse.
yes, sir.
Look here. Look in this place. What happened?
So I'm not able to visualize.
Look at the stomach, please. What happened?
Yes, sir. Okay. There is a hypoenhancing lesion in the stomach, sir.
Okay,
The
where?
bowel wall technique.
Where?
So involving the fundus.
Excellent. Okay. Show me by the
Yes, sir.
by the arrow.
So this one.
Sure. Okay, surrounded by, yes.
Yes, sir. Yes, sir. Which is causing luminal narrowing. This could be
Excellent.
uh, squamous cell carcinoma of stomach, likely Linitis plastica.
Yes, yes, excellent. It is very, very difficult. See here, see the fundus. Look, my friends, this is a case scenario of subtle finding. Look at
Yes,
the
sir.
fundus. There are hyper enhancement, and there are
Yes, sir.
mass here. Very small.
Yes, sir.
See here also. Look,
Yes.
this is a mass, and this is enhancement. So this is at least gastric adenocarcinoma. The
Okay.
fundus here are narrow. Okay,
Yes, sir.
I see. I'm talking about this only, not whole. This
Yes,
only.
sir.
Okay, so this is a case of subtle adenocarcinoma, the fundus of the stomach. Um, I think also there are here in the second part of the genome something here, but in Radiopedia they didn't mention it. Here, see,
Okay.
look here.
Yes, sir.
There are some thickening and heterogeneity, mainly hypodensity here. Here, maybe double
Yes, sir.
passage, maybe. Okay, but finally, this is a case of subtle gastric fundus adenocarcinoma. Thank you so much, my colleague. Thank
Yes, sir.
you for all. Last finding here, maybe there are some dilatation of the bilateral pelvic LCL system. Okay,
Yes, sir.
especially the left one. See here,
Mm, yes, sir.
down, down. Okay, at least left-sided hydroureteronephrosis. Thank you, my colleagues, so much. You are brilliant. It was a
Okay.
difficult session. I'm trying to cover all the atypical scenarios to save your side in the Viva exam. I will upload the record when as early as I finish rendering it. Thank you so much. Waiting for me for the next Thursday. Thank you, Dr. Omer, for your great effort.
Thank you so much, sir. Thank you so much. It was a brilliant, excellent session,
Thank
and we all
you.
have learned a lot. Thank you so much, sir. Thank you so much.
Thank you for all of you. Thank you for all attending. Thank